Hi, I wanted to talk about my safeguarding supervision group, which I set up 12 months ago with the North and South Monmouthshire cluster groups. Last year I was made a Bevan Exemplar for this project, which focuses on improving services for safeguarding in primary care. I've always been passionate about safeguarding, and I'm convinced that primary care has a key role to play in protecting vulnerable adults and children in society. Health Inspectorate Wales reports have repeatedly commented on the need for more understanding and training in safeguarding in primary care, particularly in respect to adults at risk. My idea initially came from reviewing a significant event relating to safeguarding. I believe that such events are one of the best drivers for improving practice, and I recognised how much stress this particular event had created for the clinicians involved. One of the key aims of our group is to offer GPs peer support with their safeguarding decisions and so improve their resilience. As an appraiser for the past 15 years, I'm increasingly aware of quite marked variation in safeguarding practice amongst doctors. I always ask doctors what they've been doing to address their Level 3 safeguarding accreditation. So many doctors are doing really excellent, innovative things, but there's currently no mechanism to share that best practice more widely. Other doctors, often working in deprived areas where they must have problems, are doing very little. And this makes me feel as uncomfortable as I do when a doctor tells me that they never experience a significant event. Health Inspectorate Wales in 2016-17 made recommendations to 44% of practices they inspected to strengthen their approach to safeguarding, and that figure fits with my appraising experience. The overarching aim of my group is to raise the standard of primary care safeguarding to that of those practicing at the very highest level. In the words of one of my heroes, Barack Obama, I recognise that change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change we seek. So it was time to step up. I proposed the establishment of our cluster safeguarding group. Safeguarding is challenging and highly time-consuming to do well, and it's a potentially isolating role addressing highly sensitive issues. I proposed that we develop a group of safeguarding leads from our cluster. In doing so, we form a group of experts in our specific field. In my own practice, I've been safeguarding lead for the past 19 years. My team know they can challenge me about decisions, but they tend not to because they assume I've got it covered. With this group, we're all the experts, and we've found that if you get 10 people in a room discussing a really complicated case, you'll get 10 subtly different suggestions about how to manage that case. This makes for a really interesting debate and increases our knowledge base, and after 12 months of regular meetings, we can demonstrate that it also improves care and patient outcomes. Health Inspectorate Wales note there's currently no support or specific training for GP safeguarding leads to enable them to perform this role. They suggest that general practice would benefit from increased peer support in safeguarding, and our group meets both of these recommendations. So, the aims of the group are to focus safeguarding on local issues and share best practice. Examples I've got are practices reviewing children who aren't brought for same-day appointments because that's a recognised marker for vulnerability. Practices are looking at children not brought for asthma reviews or diabetes reviews, but with a safeguarding hat on rather than just focusing on chronic disease management. At my practice, we have a vulnerable list of adults and children. So, for instance, if mum has postnatal depression, the family will go on the vulnerable list. If dad has been made redundant and perhaps the family is under pressure with finances or dad's drinking too much, then that whole family will go on the list. Then, if they phone for an appointment, the receptionist knows to give them one the same day. They don't ask them to repeatedly phone back the next day at 8 o'clock. We just try and ease their way through the practice service during their time of stress. It's a very dynamic list. Patients go on it on and off very quickly. I watched Ken Loach's film recently, I, Daniel Blake. It was distressing to watch, but I recognised that the characters in the film were exactly the type of people that we try to get on our vulnerable list and support through difficult times. By sharing best practice in this way, we aim to facilitate all practices increasing their safeguarding activities to those practicing at the highest level. We pool resources, we share protocols. We now have protocols for safeguarding children, for managing domestic violence and fabricated illness in primary care setting. We have a presentation at each meeting, and then we share the PowerPoint with each safeguarding lead so they can take it back and present it to their own team, so we're reducing workload in a constructive way. The most important and valued aspect of our meetings is that we discuss interesting or challenging cases in a supportive and confidential setting. Think Bayland. We generally discuss about 5 cases each meeting, and it's so good to get a purely clinical discussion, leaving alone medical or local politics. These discussions make us really feel as though we're making a difference. In just 4 meetings, we've discussed a broad range of cases covering coercive control, historic sexual abuse, capacity issues in the elderly, female genital mutilation, neglect, chaperones, and many more. Safeguarding cases evolve with time, so we revisit them in subsequent meetings. This means the learning goes on. So this is my strapline, my constant refrain. Safeguarding is everybody's business, but in primary care it's a little bit more our business than anybody else's, and we can make such a difference to people's lives. People trust us. We know families, we know the area. For instance, in my practice, we have a room set aside in the surgery where families will bring good quality used toys and books and clothes. We package them up and take them to the local refuge. Families often have to leave their homes suddenly because of the danger they face. The kids will sometimes leave home just in their pyjamas with nothing, absolutely nothing. Imagine leaving your home, your school, your friends, and having none of your stuff around you. Can you imagine how frightening that would be? So our parcels address their physical needs, but more importantly, at a time of lowest self-esteem and maximum anxiety, these mums and their children will feel that strangers actually care about them, and I know that makes a real difference. Our group is not for the clear-cut cases. We all know what to do with obvious cases of sexual or physical abuse. We've got our laminated pages of protocols to follow for that. Our group's for the more ambiguous shades of grey cases. You walk a tightrope between referring inappropriately and placing an already struggling family under further stress, or not referring and leaving a vulnerable adult or child at risk of further harm. So if you discuss a case confidentially with 9 other safeguarding leads who all agree and share your concern and feel that a referral is appropriate, that gives your decision credibility and gives the clinician support and confidence. Finally, I'm available for the rest of the group by email or mobile phone to be contacted for informal advice and support if they have a troubling case that can't wait for the next meeting. Over the past year, I've been contacted on average between 2 to 4 times a month, demonstrating a clear need for this service. One doctor explained he valued being able to talk to me before taking the nuclear option of involving adult or child safeguarding. We know that all clinicians now need to have Level 3 safeguarding accreditation. The group's an excellent way to achieve this, in combination with online modules and local health board multidisciplinary educational meetings. A final benefit of the collaborative nature of the group is that by sharing ideas and strengthening relationships, we're encouraged to work together in other ways. Recently, a local doctor spent the weekend updating a drug monitoring protocol. She then shared it with me, asking if it might be helpful. It was really helpful. It saved me several hours of work. The more we get together to share workload, the more likely it is that our clusters will thrive. The meetings are multidisciplinary. The core members are the safeguarding leads, but other doctors with an interesting case to present are always welcome, as are medical students and trainee GPs, who often bring a really interesting take on cases. Our health board child safeguarding lead nurse attends regularly. I was worried initially that her presence might inhibit discussion, but from group feedback, her huge knowledge base, expertise and challenging input is greatly valued by all members. The meetings have got constant high attendance. At our most recent meeting, we had a local barrister and solicitor with expertise in deprivation of liberty and enduring power of attorney join us. We had a minor crisis because we ran out of chairs. We've got consistent positive feedback with examples such as excellent opportunity to discuss difficult cases in a safe environment, peer support and friendly atmosphere highly useful, face-to-face meeting with expert makes later contact less daunting, increases awareness in consultations, which I think we've all recognised, and really good sized group for challenge and discussion, excellent informative meeting. People really like these meetings. So, the meetings meet the quadruple aims of the Healthier Wales document by facilitating local innovation through clusters, We're shifting resources out into the community and emphasising prevention of harm through early intervention and promoting well-being in patient populations. The idea is underpinned by the 4 principles of prudent healthcare, focusing on doing only what is needed, caring for those with the greatest health needs first, and reducing inappropriate variation. So the meetings are going well in our own area. The next step is for the idea to be scaled out and taken to clusters across Wales. I already have doctors interested in Anglesey, Denbigh, Cardiff and in Swansea. I had an article about the project published in Pulse, which generated considerable interest, so it's all looking very positive for being able to scale it out. I submitted a business plan to our cluster using positive feedback that I had from National Safeguarding Leads Aideen Norton and Nigel Farr. I also had the support of Vaughan Gethin, Cabinet Secretary for Health and Social Care, who was enthusiastic and agreed to follow our group as a pilot for the Welsh Assembly Government. I confirm that the group does meet the new GMC contract recommendations for safeguarding and that it will facilitate us getting Level 3 safeguarding accreditation. I used this support as well as positive feedback from cluster leads and the Associate Medical Director and was given £6,000 for a pilot for the first 9 months. This has now been made recurrent, with both clusters involved planning to share the cost. Our cluster's next plan is a pilot for optimising advanced care planning. There are many examples of significant events relating to unplanned and unwanted admissions. This is not just an issue which affects bed capacity in hospitals, it's a significant safeguarding issue for patients who end up in hospital for weeks when they'd much rather be cared for at home. There's a clear requirement from the GMC that all doctors must develop and maintain safeguarding knowledge and skills. The GMC intercollegiate safeguarding competencies are demanding. Each practice has a safeguarding lead, and it's highlighted by the Royal College of GPs that due to the multiple and increasingly complex demands on general practice, firm leadership is required to support practice staff in fulfilling their safeguarding responsibilities. This is the role of the practice safeguarding lead, but currently these clinicians are not adequately supported in Wales. I was surprised to find that England are doing things differently. They hold meetings similar to ours, but in a much more prescriptive way. There are specific people in the roles, and considerable funding is invested in safeguarding. Why does all of this matter? The evidence that demonstrates the potentially lifelong damaging effect of adverse childhood experiences is clear and compelling. We know that the emotional and economic impact of domestic abuse profoundly limits the ability of affected individuals to reach their full potential. We have the opportunity to address this more effectively. In the words of another one of my heroes, Cahill Gibran, safeguarding the rights of others is the most noble and beautiful end of a human being. And I genuinely don't believe there's anything more important that we do in primary care. So please do contact me if you want some more information. Thank you very much.